Hi everyone, and welcome to this new TechNet 21 webinar series on EIR or IIS, how to select the best digital immunization system for your country context. Today, we're going to have an introduction on DHIS2 tracker with the Bangladesh use case. You can listen to this presentation in French or Spanish. To do so, please select the globe at the bottom of your Zoom window and choose the desired language. You can also remove the background language if you want to listen to the voice of the interpreter only. If you struggle to find it, please let me know in the chat box or in the chat area. Talking about the chat box, you can already introduce yourself, and I see that we have a few people who just introduced themselves. So hi, Mohammed, Ibrahima, and hi, Dr. Sedu. You can introduce yourselves and tell us about where you're from and give us your name. You can also use the chat box if you need any technical support, and I'll do my best to help you with what I can. If you have any question during the presentation, please do not hesitate. You can use the Q&A box, which is also available at the bottom of your Zoom window. You can ask your questions at any time, and our panelists will answer them after the presentation during the Q&A session, the question and answer session. So, and finally, this session is recorded and we'll share with you the links to the videos as well as the slides. And that's it for me. So I hope you enjoyed this session, and I'll give the floor to Harriet.
Thanks so much, Alex. Thanks again, everyone, for joining today. We've got Mike Frost and Pramod Amarakun giving us an overview of DHIS2 tracker, as well as Dr. Jahid Hossain Shahid and Mohammed Masood Parvez, our UNICEF Bangladesh colleagues, presenting their implementation of DHIS2 tracker. Mike has been the product manager of DHIS2 tracker at the University of Oslo since 2016, during which time tracker has been adopted by more than 80 countries. Prior to that, he was the implementation lead for several digital health research trials with the Norwegian Institute of Public Health, and he founded the Center for mHealth at John Snow, Inc. Mike has directly supported the implementation of health information systems in more than a dozen countries in Africa, Asia, and the Middle East. Pramod is the director and a senior implementer from HISP Sri Lanka, coming from a combined background of medical, public health, and informatics. He has close to a decade of experience working with DHIS2 in Sri Lanka and several countries in the Southeast Asian region, including the COVID-19 surveillance and vaccination systems for Sri Lanka, which have enrolled 22 million people to date. Shahid has been working as a health officer at UNICEF Bangladesh since 2016 and has developed and implemented various information management systems for the extended program on immunization, such as the Immunization E-tracker, the Immunization Mass Campaign Management System, cold chain management, and microplanning information systems too. Masood has been working as a health officer at UNICEF Bangladesh since 2017 and has provided technical support on DHIS2 tracker, including maintenance of the server, the National Public Health Dashboard, the COVID-19 vaccination dashboard, as well as system integration and interoperability. Over to you, Mike and Pramod.
Great. Thank you, Harriet, for the introduction, and thank you to the UNICEF colleagues for the chance to share. I wanted to start off by giving just a little bit of background about what DHIS2 is, as it's kind of a unique software. It's managed through the University of Oslo, which is where we are now, and it has been a part of their Department of Informatics since 1994. Starting in South Africa, a collaboration between the University of Oslo and the University of Western Cape. We essentially have a distributed method of creating this free open source platform, working with 17 different health information systems program or HISP groups around the globe. The software is freely available for anybody to download and use. Many of those that are using this for their national health information system are not in direct contact with us. As the university, we do our best to make sure this is something that can be locally owned and used. We spend a significant amount of time on the capacity building and have an online academy and regional trainings, which have trained more than 5,000 DHIS2 experts to date. The software itself is a generic model that can be adapted to many different use cases, not only in health, it's also being used for education, it's being used for many different purposes. The University of Oslo is the governing body that develops the software, and we release 2 updates to the software annually. It's endorsed as a global public good by WHO, and we work with many of the global donors to make sure the platform is free and available to everybody. It's used by more than 73 countries as their national platform and covers many, many different areas for health. Just wanted to show a little bit about why there's such a big opportunity to build in an immunization registry within this software. There is already a global footprint of 45 countries using DHIS2 for their overall immunization data, their national reporting, collecting aggregated data from all across the country. 30 of those countries have installed WHO's specific EPI package, and I'll talk about these WHO packages in just a moment. And 42 countries use DHIS2 for their COVID vaccine response. This was something that was able to pivot very quickly and adapt a COVID package and implement it within their existing DHIS2 infrastructure within just a couple of months of WHO putting out guidance for COVID-19. And this shows, I think, the reach of the platform and how quickly additional components can be added to the information system. So we'll talk a little bit about how that is done. The University of Oslo is a collaborating center with the World Health Organization. And what has been going on for the last 4 or 5 years is the creation of a series of standardized metadata configurations for DHIS2. Essentially, DHIS2, again, is an open tool that can be configured any way that the country would like it to be used. But working with WHO, we have pre-configured it to match a large variety of specific use cases, building in the global standards and recommendations and indicators, developing recommended analytics and visualizations. So any country is able to go to the WHO website or the DHIS2 website and download these packages freely and add them to their existing configuration. You can see there's many different areas that are covered. I couldn't fit them all on the screen, but this is a good look at it. Working with the immunization area, we have developed quite a number of different configurations of DHIS2. These can be used standalone or in combination with one another. I won't be going into all of them, but hopefully you can see that there's a wide array of possibilities. And as I mentioned before, there are already some 30 countries that are using the EPI dashboards and analytics and the aggregate EPI metadata package. But there are many, many others that are also using the vaccine preventable diseases, the bottleneck analysis, adverse events, and what we'll be taking a look at specifically, which is the Electronic Immunization Registry tracker package. So it's important to understand what these packages are. They are, again, pre-configured with the data elements, the analytics, the visualizations necessary, but they're also meant to be adaptable. So the countries have them as a starting point with a very high quality configuration, and they can be adapted to match the needs and the use of the country. For example, they can be adapted to be used directly at the point of care with a patient, and there is included decision support, which I'll show you in just a minute. But they can also be used as a secondary data entry for the individual level data if the country doesn't have all of the devices or the infrastructure necessary to do the kind of live data entry and back and forth. It is designed to increase the data reliability and make for higher quality data information for the immunization system, and is based on the WHO position papers for routine immunization. It was developed in collaboration with the Norwegian Institute of Public Health, working with the Norwegian vaccine program, and also included the information on electronic immunization registries from the Pan American Health Organization and working with several countries. So the design for this, we collaborated also with Gavi, with the World Health Organization, and with UNICEF as we created this basic configuration, which is then adapted and used by the country based on their own needs. So just giving you a quick look at the information that is baked directly into the package, showing you that it was built around the standard routine immunization based on the child's age, but also includes a wide variety of the non-routine immunizations and can be adapted to include any that are specific to the country. Just to show you that all of this is available now, you're able to go directly and get the documentation that shows you the system design. There's a change log associated with it because it's been updated over time, so you can see what the different versions are and what has been included. There's an installation guide that's associated with it. And all of this is available already for your country to take a look at, to see if the design matches their needs, and to determine if it's something that they would want to use. So I'll show you just a bit about what are the possible functionalities that, again, can depend on how the country wants to apply this. But the software itself allows you to hide and show data fields, has pre-configured warnings, contraindications, can be linked to SMS notifications that can be sent to the mother or the client. Has a vaccine card view, specific working lists that are meant to guide the workflow of the clinicians or the service providers, and analytics and indicators based on the WHO recommendations for the vaccine program. So we'll take a quick look at this generic package, and then after that, I'll turn it over to my colleague Pamod to talk a little bit about how this has been applied in the Maldives as an example. Well, what we're looking at here is a landing page. If you were a user of the system, in this system, we're specifically at a hospital, the Cardinal Hospital Gateway, and I have a list of the basic workflow items that I need as a clinician. I can look at all of the immunized patients. I can look only at those scheduled for the week, those scheduled for today. I can look at any missed appointments for follow-up. And indeed, these can be customized to match a different workflow. If you're looking for children that are lost to follow-up, if you're trying to identify at-risk groups, all of these, there's specific configurations that can be made available within the software. Those can be done in-country by DHIS2 users. They don't need to be a software developer. There are tools within the system to be configured to match the specific workflow that you require. Just taking a quick look at how the program rules are created. The program rules are the logic within DHIS2 that allow you to adapt the fields that you're seeing on screen, that allow you to have restrictions about what kind of data, what ranges can be there, et cetera. So this is just giving you a sense of some of the many program rules that are included in the routine immunization package. It will take a look at the child's age and will present, based on the vaccination schedule, the appropriate vaccines that should be provided during that visit. You can also see, for example, that we're getting information. This is just showing you the hide and show rules for those routine immunizations. But there's also information here that is contextual based on the condition of the child. If the child, for example, was HIV positive but not on ARTs, it will give a warning that it's contraindicated to give the BCG vaccine. It can give them information about if the child has a fever, avoiding certain vaccines. Again, all of these are configurable based on the country's guidelines. What is placed in there already are the rules that are based on the WHO guidance, but these can be adapted if there are vaccines that are not being used in the country, or if you're not aiming this at the child immunization program, you can have different rules that are based on the same kind of logic, but are tailored to the vaccines that are being used in country. The layout of this in the web version is giving you this look at a vaccine card. You can, at a glance, as a care provider, see the immunizations that have already been provided. Every one of these rows in the matrix, you can click on, and it would open up the event when the child received that vaccine and any associated information with it. And that top row, you're seeing, again, kind of pre-configured information that should persistently be available in any visit, giving the name, the age at the visit, allergies, etc. Again, that information that you choose to display at the top can be adapted. It can be changed to match whatever information in the country is deemed to be the most important that is persistently available in the view of the screen. Here, I'm just giving you a look at the configuration of the SMS notifications. Again, this is optional. It depends on whether a gateway has already been set up and can be linked to in the country. It depends on if the country program or whoever is funding it has this as a priority. But there are pre-configured messages that would populate automatically. There's no manual entry necessary that can be set to run based on logic to remind them about their upcoming appointment, give them information about which vaccine is going to be provided, can encourage them to visit. More of these notifications can be linked based on the requirements in the country. They don't necessarily all have to go directly to the client or the mother. They can be sent as a notification, for example, to the manager about the number of vaccinations that have been performed. It can be linked to adverse events following immunization, and it can be sent as a notification to start an investigation into the immunization, for example. The software itself works both in the web browser for those that have laptops or desktop computers, but also works through the Android app, which is freely available through the Google Play Store or through our GitHub repository. You can have a mix of users, some that are on Android, some that are in the web, and it's all feeding into the same data set. The analytics and indicators, as I mentioned, were based on the WHO EPI aggregated program. Right now, it's pre-configured to have 5 dashboards for the overall rollout, the age ranges, dropout rates, the doses. But there's more that can be done. All of these analytics, again, can be adapted to existing requirements in country. And having this individual level data coming through the tracker program allows a very granular look at the data and different ways of looking at it. So this is just a quick snapshot of the kinds of analytics and the different types of visualizations that are already baked into this package. But these, again, can be adapted. Any of them, you can toggle between different views, whether you're looking at a map or you can switch that same data to look like a bar chart or a graph. There are many different ways to display and use this data, which is part of the power of linking this to DHIS2 as a platform. Many countries already are using this for their overall routine system. So you can have the same user able to toggle between a number of different dashboards and have a different look at the immunization data, whether it's coming through the registry or it's being reported from an aggregate level, et cetera. The last thing I just wanted to quickly mention is that part of the work that we did with UNICEF was to link the immunization registry to the birth notifications for CRVS systems. So this is something that several countries have done, using the opportunity for the child who has first come in perhaps to the health clinic for an immunization and has not been registered before. You can use the data to capture birth information and push that to the CRVS and have that start the notification process and the registration for the child as a part of the CRVS system. So with that, these slides I'm sure will be shared. There's a number of links where you can find this information, but I'm going to turn over now to my colleague Pramod to talk to us a bit about how this was used in Maldives.
Yeah, thank you, Mike. So hello everyone, I'm Pramod from HISP Sri Lanka. So in next few minutes, what I'm planning to do is to briefly explain the process on how we adopted and implemented this Electronic Immunization Registry for the Ministry of Health, Maldives. So it all started about 10 months before. I mean, beginning of the year when the Maldivian Ministry of Health and the WHO country office shared with us this diagram, so which kind of highlights all the major components of a comprehensive electronic immunization package, as you would call it, that it should have. So when you look at all these requirements, you will clearly see like some of them, of course, we can directly do on DHIS2 by adopting a package or maybe customize DHIS2, but some of them are a bit tricky. So now, if we just focus on the approach, the technical approach that we took by then was like, I mean, so most of the requirements that we had in the previous diagram, we could just directly adopt the DHIS2 metadata packages, for example, the EIR, the AFI, the vaccine preventable diseases. So you have packages. So we mostly use them. And then for some of the requirements around travelers, vaccination and supervision monitoring, we could customize DHIS2 to cater the requirements. So most of this, I mean, like the experience and why we opted DHIS2, I mean, it was not just us representing HISP, but it was a collaborative decision by the Ministry of Health and the WHO and all the partners who were involved. So we had the confidence based on our experience around COVID-19 that most of them are doable. But what is more interesting is to focus on the columns, the second and third columns, where we had to do some custom developments. For example, the beneficiary portal for letting the clients access their own records and producing immunization certificate. And then for immunization micro-planning, we had to do some custom developments. And we also had some integration requirements around ELMIS and remote temperature monitoring, Vigiflow integration. But what is significant to note here is that we adopted DHIS2 as the base platform, and DHIS2 has all this flexibility to produce custom development on top of it and to integrate it with other systems. So this again, mostly based on our learnings during the COVID pandemic, because it was all about agile developments and the integrations that we did when we were working on during the times of COVID. Right. So if we specifically focus on the EIR, so the main functions was to collect and store the data and to analyze and produce dashboards, and of course to produce digital vaccination record through the beneficiary portal. So let me quickly focus on few interesting screenshots. I'm not going to show everything what we have on Maldives Immunization Registry, but like a few things to note is like what you are seeing here is the track, we call it tracked entity dashboard. So this is the primary data capture interface where we are capturing individual immunization records. So something that you should note is like, so we have the generic DHIS2 EIR package, but we had to do some customizations to the generic one based on the country requirements. So this, of course, like you can't plan well in advance. You have to have a dialogue with the ministry and identify the requirements, and probably during the pilot, that is when you kind of identify that you have to do some configurations, some changes to that what you have in the generic package. And here you are seeing a dashboard. So in the generic dashboard, we have all the analytics in place. But when we are implementing, sometimes it is nicer to have these kind of dashboards, which are kind of, we call them landing dashboards, where we are kind of leveraging on the dashboard functionality and also like, try to highlight them as a notice board. So here we mentioned important messages, and then who to contact and how to reach out for support, things like that. So like this is again customization on top of the generic package that you have. And finally, of course, you have all the different analytic outputs and visualizations that comes bundled with the package. But then again, based on the country requirements, you might have to do some customizations and incorporate them into your dashboards. So all this, what we have done together with the Ministry of Health and the WHO and all other development partners who are involved. And again, now you have the package and you have some guidance, especially the DHIS2 tracker. I mean, and the University of Oslo conducts so many DHIS2 training programs. And so it is quite interesting to attend these training programs because like, for example, the package is just the software and the tech. But the thing is like, when you're actually implementing, you will have to come up with your own user guides and implementation strategies. So for example, what you're seeing here is a single page user guide. We don't use like this 50-page user manuals in our implementation. Again, a learning coming from our experience during COVID, like people really like to have visually rich, simple user guides. So this is one of the user guide documents, single page guides that we have developed during the implementation. Right, so for this work, it's a work of the Ministry of Health Maldives together with HISP Sri Lanka, WHO country office, and the UNICEF country office. And there were like so many other stakeholders who really contributed in making this a success. So we are kind of 2 months into our implementation, and it's quite coincidentally, like today is the date that they had the national level opening of this EIR. And as of now, the country has been able to register 35% of their birth cohort, children in the system, and they are scaling it up. So right now, they are the 50% of the health facilities in the entire country are actively entering data, and they have planned many other training programs to scale it up in next few months. So in addition, AEFI and Vaccine Preventable Diseases Surveillance Program is also customized, and then beneficiary portal is developed and ready to be piloted. So the last thing I want to quickly mention are a few learnings. So main thing is like how you would use the metadata package. So metadata package is not just plug and play. I mean, it's really important that you use it, because then you can actually see what is in the package, and you can show the ministry and get feedback. So that is exactly what we did. And during the pilot, we figured out so many areas that we might need to include and change. And then the final product is actually the metadata package and some customizations on top of it. And then again, like it's sometimes based on the country requirements, you may not really be fulfilling all the requirements using the package and the customizations, and you have to be ready to use integrations and maybe do some custom developments to kind of cater all the requirements the country needs. And then engaging with the stakeholders, you really need to engage with the ministry and go to the field and see what are their requirements. So pilot is a very good experience where you can learn and figure out the changes that you have to make sure which are there in place before you go for a national level implementation. And then again, the HISP Sri Lanka team and the UIO, we are just facilitating. So our main focus is not to make the countries dependent on us. It's more about building the in-country capacity. So we heavily focused on building capacity in the ministry. So the entire implementation is now carried out by the Ministry of Health, Maldives. And then again, scaling and providing support. So we kind of take piece by piece. So we don't go for full country implementation at one go. So right now we are kind of identifying the areas that we will be implementing on given months. So in few months, we are planning to kind of cover the entire country. So these are a few learnings that we have from Maldives example. So thank you very much.
Right. Thanks, Pamod. So we will turn now to the Bangladesh UNICEF team.
Thank you, Mike. Hi, this is Jaidusin Shahed. I'm working as a health officer at UNICEF Bangladesh. Mike, next please. Yeah. So this is the background situation why we felt the DHIS2 tracker we needed, since the Bangladesh achieved fully vaccination coverage up to 82%. However, for years, we observed that the coverage remaining static from 80 to 85%. And also we observed that there is a significant coverage gaps between the urban, rural, and some other hard to reach, and in comparison with the hard to reach and the non-hard to reach areas. And also there is a gaps between the valid and the crude coverage. And we observed that there is a big difference between the administrative coverage and the coverage evolution survey coverage. And the invalid doses, drop out and left out are the main reason for the low coverage we seen. And also denominator is one of the big challenge for Bangladesh, and unable to identify the zero dose children. So basically, we are able to address these issues through our aggregate data system based on DHIS2 from, if you say from 1 to 4, but for the 5 and 6, however, these issues which we could not address through the aggregate data system, then we have decided to introduce the DHIS2 based E-tracker system and pilot basis in some selected areas. Next, please. So our objective of the introduction of the Immunization E-tracker is to increase the valid full vaccination coverage up to 95% and establish a reliable online registration system to monitor the unvaccinated, partially vaccinated, and the fully vaccinated children. And through the SMS, built-in SMS functionalities, we would like to reduce the invalid doses, left out, and the dropout, and to reduce the gaps between the urban, rural, and the slums, hard to reach and non-hard to reach areas. Next. The requirements of our Immunization E-tracker is it should be both Android and web-based. The registration of the children as per our current manual registration elements. The vaccination record entry should be as per our current EPI schedule, and would like to send SMS to mothers or the caregivers, even for the registration, due dose, dropout doses, and also for the completion of the vaccination. And would like to show the vaccinators if is there any invalid doses they're given. So the system should be automatically alert the vaccinators that would be invalid doses. And also would like to send the SMS to the supervisors or the managers for the invalid doses, so they can track whether their invalid doses are related, they can be validated. And the list of due doses and the overdue doses, and definitely it should be an offline data entry. And we seek the country capacity, adaptability, and the sustainability. These are the basic requirements for introduction of the Immunization E-tracker. Next. So why we selected DHIS2 tracker? These are the timelines. We may say that from 2010, Bangladesh are using DHIS2 for the collect facility and the community level aggregate data. And from 2015, all the health managers and the field level users were oriented in DHIS2. And also from 2015, we collected the maternal and child health data from 14,000 community clinics throughout the Bangladesh. And from 2016, the EPI program using the DHIS2 aggregate data system for collect the EPI routine data and also the vaccine and logistic information. And the EPI also introduced the cold chain equipment inventory through the DHIS2 tracker from 2016. And we have the technical expertise, in-country technical expertise available on DHIS2. And then in 2019, we introduced the Immunization E-tracker. Next, please. So the using DHIS2 tracker module, we using the DHIS2 tracker module to register every child. And this is very flexible for the customization to design as per country immunization schedule. And it has a built-in SMS module to send the reminder even for the defaulter to the beneficiary and the health worker both. And it is also built-in indicator and notification features to facilitate the reduce the invalid doses. And there is a very advanced analytics system to reduce, to track the zero-dose children. And it has also GIS functionality to identify the service gaps in between the hard to reach and the non-hard to reach areas. And there is a automated system for the report generation to identify the invalid dose, left out, and drop out, even for the web-based app and for the also for the Android capture apps. So these are the basic implementation timelines and the steps. We did the consultation and the partners and the development for the application. It almost took 4 weeks. And then we did the field testing of the app in both rural and urban settings. And then we go for the development of the guideline, then the capacity development of the health workers and the health managers, and then implementation and continuation of the supervision and monitoring and the review. So this is our implementation status. We implemented in the DHIS2 Immunization E-tracker in both rural and urban settings, also for the humanitarian responses. And you see, we covered more than 3,000 immunization outreach sites through this Immunization E-tracker. And for the humanitarian responses, we use this DHIS2 tracker in 32 camps in 56 outreach sites. Next. So this is our E-tracker child immunization pictorial. So we developed, we customized the DHIS2 tracker as we said that as per our immunization schedule. So there is a multiple stages from 0 dose to the second dose. And the immunization in Bangladesh, immunization structure are using the both fixed center basis and the outreach center. So, and the both health workers in the fixed center and the community health workers also in the Upazila health complexes, they both registered the children in the DHIS2 E-tracker. And soon after the registration, there is a confirmation SMS sent to the mothers or the caregivers whose mobile number are recorded in the system. But the child with the immunization ID, the unique ID that this child is registered in the immunization tracker, And for all other doses, there is a reminder SMS sent to the mothers or the caregivers to remind them this next day is their immunization schedule. And even if they misses to get the immunization shot, then there is a defaulter SMS also sent to the mothers or the caregivers with the information of the health workers' mobile number that they should contact with the health workers to get the immunization shot in the next session. Next. So what is the benefit and the added advantage of this Immunization E-tracker? So we conducted a implementation research for the E-tracker implementation in June to August 2021. According to the implementation research report, that the E-tracker system is aided for the easy tracking of the dropout children. And also it's using the E-tracker to help the vaccinated to identify the dropout children and avoid giving the invalid doses. And the program also aiding to notifying the beneficiaries via the SMS to ensure the valid and the effective vaccination processes. Next, please. So what are the contracting options and the cost categories? Since DHIS2 is open source and free, we all know that. So any local vendor or the HISP can implement this immunization registry. And also we can get the support from the University of Oslo. The cost categories are very scratch here. The server infrastructure cost, the cloud, if the country can decide, they can go with the cloud service also. There is a devices and accessories, SMS cost involved, the training, monitoring, and supervision. And for sustainability, there's an annual maintenance cost involved. Next. So what's the pros and cons? So this is a truly open source software for customization and implementation. And the DHIS2 has a strong community support, we all know. And this is a very flexible for customization to design the E-tracker and the Immunization E-tracker. And it has a very version upgrade in regular interval. There is no vendor lock, and it follows the international standard for the security and privacy. The challenges are the system performance. It could be affected based on the server capacity and the tracker design also. And the global search, we observed is a bit tricky in terms of the configuration and the printing of the vaccination card. It needs a spatial scale. The server configuration and the maintenance of the DHIS2 is also need spatial scale that system. And we face the difficulties to interpret the system error log. Next. Yeah, thank you.
I'm sorry, I think, is that the last slide? It's not.
Yes.
Great. So thank you so much. So I'm just seeing a couple of questions that have come up in the Q&A section. So I'll point them out, I think, to both Pamod and the Bangladesh team as well to answer if they'd like to. So the first one, I think, relates to the Maldives VigiFlow integration, asking about whether this was automated or a manual process. I can say just a word about it, but then ask maybe about how Maldives specifically did it. So we at the University of Oslo had collaborated with WHO on trying to make a connection to the global repository for adverse events, which is called VigiBase and is based in Sweden. They have a specific software called VigiFlow that is used for reporting the adverse events following immunization. And we worked with their software team to connect DHIS2 both to VigiFlow if a country is already using that as software, and also as an approach to be able to report directly from DHIS2 to VigiBase, the global repository. And we created some specific tools to enable this. It's still a country by country kind of implementation. We supported and learned from Madagascar, setting this up in the first place, and then conducted a couple of webinars with the DHIS2 community to put the information out there about how it can be done. And so that's from the global level how we had worked on this, but then happy to have Pamod give us some more details on Maldives.
Yeah, thanks, Mike. So actually, just like Mike highlighted, so again, our learning comes from the global team. So because this was something new, but our approach was that we didn't want to kind of reinvent the wheel. So we contacted the UIO to see like whether there's any global effort in integrating VigiFlow. So what we are currently doing, I must mention this is not fully implemented yet, but we have developed it. So UIO has some guidelines on how this EIR package can be integrated with the VigiFlow. It's kind of I mean, like there are a couple of steps in doing that. So the first thing is kind of you produce, so you configure producing an output. So it's a kind of like a spreadsheet that we produce on a weekly basis. So once this, this output is produced, it's a file. Somebody has to manually upload it to the VigiFlow. So to be very specific to the question asked, so it's not fully automated right now. There's a kind of manual intervention present because they want to kind of, it's always to check what is there and whether it is accurate. So once that, we produce this output file, it can be uploaded into the VigiFlow system, and that's the kind of integration that we have at the moment. But then again, this is a very generic thing. So as per the country requirement, like say if a country wants a fully automated system, I don't think it's a major task in making it fully automated. Just that you want to be very mindful of the process involved and the consequences. So in Maldives, the approach right now is a kind of you produce output which is manually uploaded into the VigiFlow.
Thanks, Paul. The next question I see is a question about how long it takes from design to full deployment. So maybe I would turn to Bangladesh. I know you spoke a little bit about that in your presentation. Do you want to just repeat a little bit and give some information about the timeline from the point when you first started looking into this to the point where you actually had a deployment?
It actually depends. There is a multiple segment you see from the design development up to the implementation. So if the country can manage simultaneous activity, then it can be done within 8 weeks. Other than it will take maximum 12 weeks from design to the fully developed deployment.
No, great. Yes. I would say that just in general across many countries that we've worked with, this process is variable because it often is about getting the requirements agreed to. And that process itself can take a long time depending on the stakeholders and who has the authority to make the decisions. Once the requirements are fully agreed to, the configuration itself in DHIS2 it doesn't have to take very long if you have a skilled team that already knows how to use DHIS2. But that again is dependent on how much you can reuse of the existing and recommended package versus starting from scratch. There also can be significant time that goes into things like integration if you're trying to be interoperable with existing systems. So it is variable. You could start today and download the package into just a development instance, and you would already have kind of a working tool. But the agreements with the country and moving forward on interoperability and then taking the time to train, all of those things are very dependent on the resources available in the country and those things. Okay, we have a next question here from the Philippines, specifically about the health ministry is already looking at how to integrate surveillance systems and look into this. How could they request technical assistance or a demo of DHIS2? So from the University of Oslo side, we'd be happy to join in initial conversation and share some information. But we also have a number of regional partners that could be of support to Philippines. So we have, of course, Pamod here from the HISP Sri Lanka team. There are also teams that are based in Vietnam, teams supporting in Bangladesh, as mentioned by the Bangladesh UNICEF team. So there are a number of groups that are regionally supporting various countries and could be available to join that conversation as well. So feel free to reach out to me if you want to start up a conversation. It's mike@dhis2.org, very easy to reach. One more question about offline use of DHIS2. The Android version of DHIS2 is what we consider our offline offering because the system it can be locally hosted or it can be hosted in the cloud. It can be accessible through the web or Android, but the web access is designed like a web browser. It's meant to be for a persistent internet connection. For offline use, Android stores data locally and can sync with the server when it's able to get a connection. And there are many, many countries that are using this as their offline approach. So it would be through the Android approach that you'd be able to collect and enter data if you don't have reliable internet and you need to be offline. Of course, this comes with its own challenges of ensuring that there are Android devices and doing management of those devices, specific training for those devices. So it's definitely a question of proper implementation and figuring out the approach for your country, but that would be the offline approach. Okay, the next question that I'm seeing here is about the annual maintenance cost. So again, I would be happy to have either the Bangladesh team or Pamo jump in a little bit. I would say again, this platform, unlike many of the other systems you might be looking at, this is not a licensed platform, and the University of Oslo team is not doing software as a service for this platform. So it's not something that you set up a maintenance and ongoing cost with us directly. Each country typically already has their own DHIS2 infrastructure. They're using it for something already, so it's already hosted, usually in a local instance and being managed by a Ministry of Health in their own servers. But it can be hosted in a cloud instance as well. But all of that, again, is kind of a local decision and local ownership. But there has to be a technical team that is supporting the DHIS2 installation. So it's just like any other large information system. There has to be an IT team that is making sure things are running, that the system doesn't go down, that has to be on top of changes. For example, if there's new health facilities that come online or new users that needed to be added to the system. So there has to be a technical team managing that. Again, that is often being done in combination between a Ministry of Health IT team and with outreach or support from another organization, often a HISP organization like the HISP Sri Lanka team here that is supporting Maldives, for example. But there are many different iterations of that. There's a very large community of DHIS2 service providers. And what I would recommend for any individual country here is to look into the use of DHIS2 that's probably already happening in your country. There's some 90 countries that use DHIS2 for some purpose. And so there's very likely already a technical partner. There's very likely already a DHIS2 installation. And if the interest is in adding an immunization registry, then those would be the local partners that you would already work with. I don't know, from Bangladesh or Pamod from the HISP Sri Lanka team, is there anything you would add to that in terms of annual costs or IT support?
I mean, like, just to keep it short, so just like Mike highlighted, so it all depends on how institutionalized your DHIS2 implementation is and the capacity within the country. So when it comes to this maintenance, you have some costs related to the infrastructure, like this is mainly the hardware and network and related services. This, of course, you will have to bear whatever the implementation that you do. But the human resource involved with maintaining the DHIS2 implementation is what really matters. So general approach of HISP has been to kind of build capacity within the ministry. So it's not just that you are using DHIS2 for immunization. So generally it's a case that you will be using for multiple programs. So if you can really pull up your resources in maintaining your DHIS2 implementations within the capacity of the ministry and within the country, so then you will have minimum operational or maintenance cost. So that's the kind of strategy we recommend most countries to adopt.
Thanks.
Yeah, exactly. You were mentioning both of right. There's the recurring costs are mostly involving the HR, and the country decided if they are using their own server system. So there's the recurring cost also for the Immunization E-tracker. If you would like to use the SMS functionalities, then there is a recurring cost. You have to calculate the SMS cost per child, per fully vaccination child. So these are up to actually depends on the country to country. Thank you.
And as I said, there's very likely in your country someone who already has this DHIS2 infrastructure, and they would be very capable of helping plan out kind of a budget and what the ongoing costs might be, because they're already using it to support something. If that is not the case for your country, we also have a number of tools online through DHIS2.org and through our docs.dhis2.org, where you can have some more information about how to plan an implementation, what the timelines look like, what the costs might be. So those can be used if you need to kind of start from scratch. The next one, maybe I'll ask the Bangladesh team first and then come back to Pamod. So it was questions about the challenges encountered with vaccine card printing and server configuration and maintenance. What are the skills that are needed? So Bangladesh, you had identified that setting up the configuration and maintenance is something that requires skills. Do you want to talk a little bit about how that went with your implementation?
Yes. So the DHIS2 tracker from you can directly print the vaccination card from the the tracker from the it's just recorded the information. So printing the vaccination card or developing the vaccination card printing system, you might need some other interoperable system, or you can use the Jasper engine. And for the server configuration and maintenance, yes, Mike already mentioned that the expertise on the server configuration and maintenance, it's a challenging for us actually. So it's depends country to country actually.
Yeah, and maybe a kind of general thought of this is that the system itself can grow. Of course, if you're trying to do an individual level system for every child entered into the routine immunization program, it can grow to be a very large and very active server-based implementation, and you would want to have an actually very skilled systems administrator that is a part of the team. So if this is meant to be something that each day during work hours is receiving thousands and thousands of transactions, then it's something that you need a robust server environment, and you need a highly skilled IT person to ensure that you don't have the system crashing and going down. So maybe I would ask Pamod to talk a little bit about this. I know that you've run a very large COVID vaccine implementation, for example. What are the kind of considerations that the UNICEF and others that are listening here should have when it comes to trying to stand up a system like this?
Yeah, so this, of course, I will not stick to the Maldivian use case because again, like it's when it comes to the numbers, it's a small implementation. But coming from the implementation experience around COVID vaccination in Sri Lanka, where we had more than 20 million people registered, almost the entire population. So the thing is, like, there, when you are thinking of, the approach, so we have multiple approaches, which has been discussed in many other webinars when it comes to producing immunization certificates integrated with DHIS2 platform. So the approach that we took, which is a kind of a complex one in Sri Lanka, was to integrate with another digital public good. So there, the inherent challenge was that it's again a new digital public good, and it has different server requirements, and when it comes to resources, the requirements were so diverse. So our strategy was, one thing is to kind of have the DHIS2 configured to be interoperable. And the next thing is to kind of get the support from the other, like, for example, in Sri Lanka, the ICT agency. So that's the kind of government tech agency. So they are managing the servers related to the certificates. So because the thing is, like, the more platforms, because we talked about integrations, but when you have many variables, like many different systems that you try to integrate, managing servers and managing the integration middleware is a main challenge. So the strategy, most of these developing the countries in low and middle income range, what we can recommend is that you should pool up your resources and have collaborations between central government agencies and kind of identify the central body which is in charge and have the capacity to manage this implementation. So that's the approach we took, and so that has really worked so well so far.
Thanks. And maybe one more word on this that is kind of relevant overall to the implementation is that the DHIS2 and the tracker system here are, again, configurable. And we've shown you from this package maybe the most complex way to do this, which is to include all kinds of things like decision support and SMS notification and integrate with other systems to have a public portal, all of these things. You don't need to start with that. And it should depend, I think, a lot on what you're trying to achieve in the country. What is the main reason that you're looking for an immunization registry? Most countries right now don't have digitized individual level data at all. What they're relying on are the aggregated numbers that are coming up at some level in the system. And below that, they're using just local records, often local records on paper. And so just digitizing individual records, if you didn't also include decision support, if you didn't include SMS notifications, just digitizing individual records is a huge step forward. It already provides you much more comprehensive analytics, much more granular analytics, ways to be able to interrogate the data that would give you a much better basis for making decisions as the vaccination program. And that's much easier to also manage as a system. It can be done by a less, skilled team in terms of their DHIS2 knowledge. The server requirements would be lower because you wouldn't be doing as much processing through the server. You could also start on a smaller geographic basis. And so over time, as you gain experience from digitizing this individual level data, you can start to add in additional functionality. So the DHIS2 can be updated and upgraded over time. You can add in more and more complexity as the country becomes used to doing this. So it is very important to kind of think of the objectives of what you're trying to attain by rolling this out, and start with kind of that as the basis for designing the system. You can always exclude any portion of the package that just isn't relevant or that is too complicated for the environment that you're trying to achieve. So I have one last question that I can see here, and it looks like we're close to end on time. The last question was about that Android offline version and whether it has the same functionality as the web version. The answer to that is yes. We try to have complete feature parity between web and Android. They do have, of course, their own development cycle, and we are constantly updating DHIS2 with 2 main releases a year. Android often has a few more releases than that because they're adding additional functionality. So there are, as far as the base package that I've shown you goes for Electronic Immunization Registry, it's the same features that we're using. They also can do all the decision support. It also can trigger these SMS notifications. They have local analytics on the Android device as well to look at the data that is just stored locally in an offline environment. But there is right now not a specific vaccine card visualization for like an individual within the Android version. And there will probably be a step forward in the way that working lists, for example, work on the web before it goes to Android. But again, these things kind of lag only by some months at time, and the development is ongoing at all times. So there's essentially the same system between the two. So I think we are out of time and just finished questions. So maybe I'll turn it back over to the UNICEF staff running.
Thank you very much, Mike. Well, that was a great presentation, and so thank you, Mike, Pamod, Shahid, Ariet, and I would like also to thank our interpreters, Emily and Naya. If you have any question in the future, you'll receive an email with the links to the recordings as well as to the slides, and we'll provide you with an email address in case you would like to ask further questions. So we hope everyone enjoyed this session, and we hope to see you next week for the next session on this webinar series. In the meantime, take care and see you next week. Thank you, everyone. Bye.